Thank you, Dr. Demirjian, for being here. I'm so excited to hear your presentation. I know that you're a big fan of sequential SLED, as am I. And I was just hoping you could kind of go into us for a bit, your uses and your experience at Cleveland Clinic, just to illustrate, the overall impact on patient care and operational effectiveness.
Thank you. Thank you, Cynthia. The talk today is about 30 minutes, so hopefully we'll have plenty of time for questions and answers at the end. And then I know there has been some questions which been submitted as well. I'm hoping some of those questions will be answered throughout the talk, but I'm sure we'll have plenty of time to address some of the other questions. So the basic outline of the talk today would be talking about, let me see if I can, yes, here we go. We'll talk about our medical center, Cleveland Clinic main campus at Cleveland, how our current dialysis program is, how SLED fits into our program in our daily practice. And then we'll talk about SLED in general, the way typically used. And then we'll talk about why sequential makes a lot of sense in perhaps most of the cases or scenarios that you're going to face with. At least that's how we feel in our center. Just a quick trip down the history lane. Some of you might recognize the physician who's leaning in the back with the glasses on. That's Dr. Kolf, father of dialysis. And this is the repurposed Maytag machine, famously being used. This is a posed picture. But the reason I bring this up, part of it is when dialysis first started, actually, duration of dialysis was not 3-4 hours. It was much longer. What you think about SLED nowadays, that was the time frame. And as many of you know, the first dialysis treatments happened right after the Second War with the rotating drum that Dr. Kolf invented, and he sent out ahead of him to the U.S. side, to Montreal, Boston, New York, Seattle. Those are some of the places he donated his invention. But then he was actually recruited to Cleveland Clinic, and he started our dialysis program in 1950. And he actually had a big hand starting our kidney transplant program as well in 1960. So we've been doing dialysis more than 70 years. And then a couple of decades later, when the first reports about continuous dialysis came out from Germany, Dr. Paganini has been already working on slow continuous ultrafiltration, and that has been reported as early as 1980. And our continuous program for critically ill patients have been initiated since then. The reason I bring this up because first of all, it's been a while. It's been several decades, and if you look at the breakdown of the main campus at Cleveland Clinic, we have a proportionally much higher ICU presence with ICU beds approaching 300. That number is a little higher than what's depicted on the slide, meaning we care for a lot of sicker patients nowadays, but our approach to some of these patients hasn't necessarily changed much. And if we look at the main campus, at least in our center, we do about more than 15,000. This is 2022, more than 15,000 in 2023 treatment days over 1 year. That includes continuous or SLED or intermittent dialysis. But then if you look at what we offer these patients, usually we're pegged into either 3-4 hour treatments or all the way to continuous dialysis. And when we say continuous, typically it's 21 hours because most patients don't run continuously. And there's always reasons, either technical reasons that has to do with the procedure itself, or the patient needs to be somewhere else for surgery, procedure, or other stuff that needs to happen. But then when you think about it, we try to fit the patient to these schedules, right? So it's either 3 or 4 or continuous, but there's a whole lot of variation in between that we don't really tap into. And this is the part where SLED fits in, where the mindset is, well, let's not try to fit the patient to what we can do, but let's do what fits the patient or what's best for the patient. And I think that will be more matching the duration or time to the patient needs rather than the other way around. And that's why SLED comes back into the discussion after decades of getting used to this notion that intermittent and continuous should cover everything, and that should be the end of it. So I disagree with that thought process, and hopefully I can convince you by the end of the talk. Now, and this is the whole crux of the adaptive therapy. In solute control, in many ways, it's not really as challenging. It's more volume control. But now you want to have a machine which will give you the flexibility to rev up that clearance to a certain intensity if you need to, and then slow it down to what continuous dialysis does. And that's very powerful to have that in one machine. And of course, on-demand dialysate production, the way you're used to with intermittent dialysis machine, where you can just change the jug and have the potassium that you need. You have much flexibility in the sodium that you prescribe because of conductivity changes. You can actually introduce sodium changes within the range that you're used to with intermittent dialysis, which you don't with continuous dialysis. And the fact that a machine like Tableau, which is very software heavy or software enabled, can actually do automated treatments for you, where the shutting off dialysis or starting UF only will be automated, and it's not going to introduce yet another opportunity for human error, but it's going to happen as the machine does it for you without you thinking about it. So now the volume control, as I said, I alluded earlier, is the challenging part, especially in the ICU. I seldom worry, did I do enough dialysis for these patients in terms of solute control? Because potassium is high, well, you can always use lower potassium bath, so that's not an issue. Usually time, duration on therapy, in my mind, translates to volume control. And when I say let's match the patient's needs to the dialysis duration, what I mean is, what's the safest UF rate that we can provide for these patients and reaching our UF goal? You can always compromise on your UF goal and say, okay, well, the patient doesn't tolerate it, and the only option I have is intermittent dialysis, then I'm not going to worry about taking the fluid off. But you have done disservice to the patient, because that translates to longer mechanical ventilation, that translates to longer time in the ICU, longer time for wounds to heal, and the antibiotics to distribute in the very swollen edematous extremities, if that's the case. So volume control becomes, front and center in a lot of the things that we do in the ICU for these patients. So let's go back to traditional or typical SLED therapy that we're used to, and there are a lot of centers who've done this for a long time and very successfully. And one of the issues with traditional SLED is each center does his own thing. There is no standard. For example, continuous dialysis, now we have a standard dose that we've learned from ATN trial, from the Renal trial, back more than 15 years ago now. But then with the SLED itself, you can have a protocol which is based on an 8-hour treatment or 10-hour treatments or 12-hour treatments. And then a lot of times you restrict variation, hoping that you don't drive everybody else involved in the care crazy, especially pharmacists or people who are trying to dose antibiotics or anti-epileptics. So you end up converging to a certain protocol and using that. Now, and that could be problematic for, especially because you don't have enough data to support how medications need to be adjusted. And then if you end up changing the duration, as I alluded to earlier, that volume should drive really what you do with the prescription, then that inadvertently will translate to increased clearance or decreased clearance unless you adjust the rates to the certain extent. But there's a lot of guesswork, and that's where the complication. And a lot of people, if you're not into it or you're not somebody who's done a lot of work with the SLED, then it gets a little too complicated. And that's the part that where sequential SLED comes into, and we'll talk about that in a second. It's very easy with traditional SLED to overdialyze the patient. It's very easy to drive the phosphate levels very low. It's very easy, if you're not used to SLED prescriptions, the potassium to get very low. For example, very seldom you use 2K bath the way you used it with intermittent dialysis with the SLED patients. And a lot of times even 3K might be very aggressive depending on the rates that you're prescribing. So there is a certain learning curve from if you're used to prescribing intermittent dialysis. And drug dosing is really front and center. We talked about that a couple minutes ago, but antibiotic dosing, antibiotics, let's face the facts, that's what saves the patient. And it's very crucial in septic patients that they have antibiotics started on time and they stay therapeutic. And unfortunately, if you look at the data out there, and never mind the slide, don't worry about the specific medications which are listed on the left. The point of this slide is that the highlighted ones are the ones which we don't have data about pharmacokinetics while on that particular therapy. So the one which has the most highlighted, which says no data, is SLED, or prolonged intermittent kidney replacement therapy. The point of this slide is we know a lot about antibiotic dosing with intermittent dialysis. We're doing better with continuous dialysis, but we are way behind with SLED therapy and proper antibiotic dosing. And that's even more challenging because not every SLED, traditional SLED prescription is the same. So even if you have some information about a particular antibiotic for a certain SLED prescription, that might not be identical to the SLED prescription that you're prescribing for that patient in your medical center. So the point of this is not discourage you, but point out that there is perhaps a way that you can do the most attractive part, SLED, which is volume management, and sidestep some of the pitfalls. And that's where sequential SLED comes in. Now, sequential SLED is nothing new if you think about it as sequential dialysis. Excuse me. Sequential dialysis has been around, and I'm sure a lot of the people, nephrologists at least on the call, have done either in their training or in their practice in certain situations where they want to avoid hypotension, they at least done or thought about doing sequential SLED, which is basically saying with sequential IHD, which is basically saying that I'm going to separate dialysis part where I clean the blood, the diffusion part, from the fluid removal part. So I'm going to do UF only, volume removal only, and then a switch to dialysis only. And this was more in use in the 80s and 90s because at the time we used acetate for buffer, and since then we moved on to bicarbonate. But acetate had the side effect of vasodilatation as well. So it was not uncommon for most patients to have hypertension during diffusion-based phase of the dialysis. So there was a lot of programs who've done sequential dialysis in some of these patients. But even today, as I mentioned earlier, where you have solute clearance, where you're removing BUN and other solutes very aggressively because of dialysis. Sometimes doing the UF at the same time might be a double whammy, and sometimes you can separate the both and do and perhaps be more prone to hypotension. So those are the top process for sequential IHD. So sequential SLED is similar. It's not identical, but maybe graphically it makes a little more sense. So let's start with the intermittent dialysis. So this is your typical, it's about 4 hours, high intensity, and usually UF rates, we typically try to limit it to 10 to 12 mLs per kilogram per hour and not be more aggressive than that. And sequential, intermittent sequential is when, as I said, when you have the blue part, which is the UF, separated, then you do it for an hour or two, and then you do the diffusion part later. At least typically that's how it's done. Now, when you talk about SLED, as I said earlier, you have different people, different folks, different centers, different protocols, which have different durations, different dialysis intensity, and different UF rates. And sometimes for the same patients, the day after, you might change your prescription. But that variation that you introduce and the lack of data for antibiotic dosing, anti-epileptic dosing, that poses a huge issue in these patients. So what is sequential SLED? Sequential SLED, basically, think of it this way. You're doing regular intermittent dialysis for 4 hours. Excuse me. Drink some water. Now, instead of doing the ultrafiltration part only for that duration, what you do is you cut it down to a lower UF rate, and you do it longer. And you do it, and you continue doing it after the diffusion part has stopped. This is the way we do it in our center. So in many ways, you start with both, but you continue the UF rate after the diffusion part has stopped. What's the upside of that? The upside is you can dose your medications, the antibiotics, the anti-epileptics, as if you're dosing for intermittent dialysis, because the drug removal or clearance after that 4-hour mark where you stop the diffusion part, it's 5% or less. That UF rate is very negligible how much effect it's going to have on your pharmacokinetics. And there is a study which was just recently published which compared this excuse me, to traditional intermittent dialysis and other traditional SLED therapies, and it shows you some of these differences. Now, in our center, we limit your UF rate to 300. We want to deliver the lowest UF rate that we are typically delivering with continuous dialysis, and we think that's safer for you and safer for critically ill patients and safer for protecting residual kidney function. So what happens is the duration of the SLED sequential is a function of how much UF goal you set yourself to achieve for that patient. For example, if you have a 300 mLs per hour as your limit, then if you want to take 1800 out, that's 6 hours of your SLED sequential, where you have 4 hours of diffusion, that's 6 hours of 300 per hour UF removal. If you want 2400, then it's 8 hours. If you have 1200, it's 3600 and 12 hours. And you want to increase it to 18 hours or 24 hours, you just do the math and increase it. And of course, you can do a lower UF rate if you choose. If you think the patient is on hemodynamically tenuous and is on a little pressors, but you want to keep them even or be a little negative because you want to help with the weaning, then you can do, instead of 300, you can do 200, 150, whatever the patient can tolerate, and then extend the time. Match the prescription of the duration to the patient need rather than the other way around. And what's the upside compared to continuous? Well, we have a lot of patients, especially, unfortunately, some lung transplant patients, for example, who are harder to wean and they're here for a long time, and they want to do their weaning trials during the day, or they want to mobilize other patients during the day. And then it's very easy, instead of doing a 24-hour treatment, or continuous dialysis treatment for that patient, you can put them on 18 hours or 12 hours and give them a time during the day to mobilize or do vent weaning or whatever else that needs to happen. Hopefully that makes a little sense in terms of differences in the modalities. Now, how we prescribe it. So the left side is traditional SLED. This right side, which is the SLED-S, is the sequential, where you do the 4-hour diffusion and the UF rate that goes for the duration. Typically in our hands, we do anyone who's not doing intermittent, basically 6 hours and higher. So you fit into that SLED sequential prescription. And we typically prescribe between 6 and 18 hours. You can do longer if you choose to. Excuse me. The dialysate flow rate, so this goes back to some of the challenges with the SLED, traditional SLED, where you try and lower the dialysate rate so you can lower clearance depending on your duration. And it becomes a guesswork in a lot of sense. Guesswork not only in delivering a safe dialysis dose, but also not removing all the other medication as we talked about. I know I'm repeating myself, but I think that's a very important factor that we always need to keep in mind whenever we're doing a therapy, which can actually remove things that are saving the patient's life and actually make a difference in them getting better rather than only maintenance. With a SLED sequential, however, that 4-hour treatment, the dialysate flow rate, I max it out with Tableau, which is 300, and the blood flow rate, I match it either 300 or 304 or up to 400 because I want to deliver an intermittent dialysis intensity treatment for that 4 hours. And the beauty of that is if you were overzealous with your UF goal and at 7-hour or 8-hour, the blood pressure dropped and the patient is not tolerating even the 300 UF rate that you prescribed, then you can stop. And the upside is you already front-loaded the patient with the diffusion part, that the potassium is under control. The patient had a buffer load, their acid base has improved, and you've corrected all the other stuff. And now all you're dealing with is the volume control. And then you can reassess and adjust your treatment for next day, but your clearance stayed constant, standard, and no changes. Versus anytime SLED therapy is interrupted or extended, you are changing your clearance as well. Now, in terms of the rest of the prescription, again, the SLED sequential, the beauty of that is if you've never prescribed the SLED in the past, you just have to prescribe intermittent dialysis rates. The 300 and 400, because that's the device that can deliver for you. But the potassium, the control of potassium is the same. Bicarb is the same. What you do with anticoagulation, my first approach is, I know there was some questions about this, automated flushes that you can do with Tableau. That's another boon for the system, especially when you're doing longer therapies. That's my go-to modality. And then if that doesn't work, I add heparin to the system. But automated flushes is one way of dealing with it. That's what the bedside ICU nurse does in intermittent dialysis therapy anyhow. Whenever the TMP or transmembrane pressure goes up, they're flushing the kidney or the filter, hoping that the clotting does not interfere with the treatment. And typically, I try and keep that 4-hour diffusion part constant. You can obviously change it from treatment to treatment if you need to, or decide on some other duration or intensity. But I try to keep it constant and then change the filter size if I need a little more clearance, if I have to, especially if we've done some studies in intermittent patients, because of the 300 dialysate flow that you use with these patients, 90% of the patients have catheter-related restrictions on blood flow anyhow. But a lot of times, if you want more clearance, it's much easier to use a bigger filter. We use F250, and that practically evens up the clearances compared to if you were using a higher dialysate flow of 500 or so with an intermittent dialysis machine. So that's something I rather do, change the filter rather than play around for the prescription that we use for the diffusion part of this SLED sequential. We talked about drug therapy and drug dosing quite a bit. The other factor is, well, with any intermittent therapy, including SLED, we don't use solutions that have phosphate in them. Even though intermittent dialysis is not very good in taking phosphate out, but a lot of these patients in the intensive care unit might not have very high phosphates. And even if they do, it's very easy to get rid of phosphate the longer you stay on the machine. And not surprisingly, when we compared about 600 patients with traditional SLED on the left side, with sequential instead, the 243 on the right side, this is the basic prescriptions, which the people on sequential were on longer therapies and had higher blood flows and higher dialysate flow because it's the 4 hours. But what you notice is people who had traditional SLED, and in this graph, traditional SLED is the one on the right side, as you would expect, that longer therapy with diffusion over 8 hours, 6 hours, or 10 hours will drive your phosphate down. When I talk about over-dialysis, this is one of the reasons I talk about over-dialysis. You can define over-dialysis by removing some of the essential stuff that your body needs, including phosphate, because if you don't have phosphate, you don't have ATP. You're not coming off that ventilator that easy. Your diaphragm doesn't have ATP, the muscles, to get you off the mechanical ventilation. So it's very important. It's something we need to pay attention to. And in fact, traditional SLED is 3 times more likely to have severe hypophosphatemia compared to sequential SLED. And that's not surprising. Everybody who's done dialysis in chronic units, with shorter therapies, you have trouble taking phosphate out. So that's not surprising at all. Now, operational considerations. So while you can turn around and say, well, SLED has been going on for a long time. There are a lot of centers who do SLED. And a lot of times SLED is done because you don't want to invest in a continuous dialysis infrastructure. And a lot of times what the necessity drives the process where, you say, okay, well, instead of doing intermittent dialysis, let's extend the therapy to 8 hours with the same intermittent dialysis machine and lower the rates a little bit. And the patient is sicker, so that will fix the problem. And it will. The problem is, if you put a program together with the traditional dialysis machines, they are very specialized. You need specialized trained nurses to run them. They're staff intensive. They're operationally challenging. And that's one of the pitfalls. We've tried this in the past before we started using Tableau for SLED. It's very hard to construct a program where you can rely on the bedside ICU nurses or technicians to run the program for you, because these are very specialized machines. So staffing becomes a big issue. Now, fast forward to continuous dialysis to be used as SLED. That's always an option too. The problem with that is it's hard to do sequential. When you want to do that higher intensity upfront, intense 4-hour dialysis, you need to be able to rev up your dialysate flow to 300, which is really sufficient, but it's the limit, because otherwise you need to do much longer. And if you do much longer, then you're outside the range of intermittent dialysis, and then antibiotic dosing becomes a guesswork again, because we have a lot of information about intermittent dialysis. We have the most information about how to dose medications for intermittent dialysis. But as I said, SLED, anything like 6 hours, 7 hours, 8 hours, 10 hours, it becomes a guesswork. Now, we just hopefully got over COVID years, but we're still feeling the nursing crunch or the shortage of dialysis nurses and whatnot. And that's one of the things that you can, when you have a machine which is a little more easier to train people to use, easier to have people get be able to troubleshoot, that process makes it easier to step away from highly, very specialized nurses, need for nurses, and then have so you don't have to be very limited to what you can offer these patients in terms of timing and duration of therapy. We all nephrologists suffer, with the same restrictions. You come to your hospital service. There has been a couple of patients who were admitted overnight. You had a full schedule of intermittent dialysis patients who need to be done. Now you add 4 patients. There's not enough warm bodies to do them all. And then there becomes a rationing process. We say, okay, well, this patient, maybe we did him yesterday. We wanted to do an extra session today, but we're not going to be able to do it, or do something else. The modality of doing SLED therapy introduces yet another pathway or a way of dialyzing these patients, where you can offer more technology use, instead of where you have more people, ICU folks or technicians who can do several patients at the same time. They set them up and they ground on them, where they can offload to the ICU nurse to monitor and come back and take them off. So you can have efficiencies introduced to your system. And of course, we can talk about this in the Q&A section. Now, that's the reason Tableau made sense to us, in a sense, a couple of years ago, when we started piloting with Tableau in our units, because it does have that flexibility. It sort of straddles what intermittent dialysis does, because it has on-demand dialysis production. You can have the flexibility of using the potassium baths, and change the sodium and change the intensity of dialysis all the way to intermittent dialysis intensity, all the way down to 50 mLs a minute, which is about 3 liters an hour. And you do it with one machine. And then you need a way of doing it safely. And that's where sequential comes in, where you can do intermittent dialysis, you can do sequential for anything in between. And then if you do longer treatments, then you can do 50 mLs per minute. Now, we'll talk about cost effectiveness too. We sort of talked about this already, that you can do SLED therapy, even though you can't do automated sequential in some of the other modalities, but you can do a SLED therapy, or at least traditional SLED. But even then, it's not very cost effective. The problem with the intermittent dialysis machines are they're very hard to train people. You need specialized nurses. They're complicated. Then staffing becomes the bottleneck, where you need to have specialized nurses to do it, and that adds to the cost. And to be honest with you, cost even doesn't come into the equation, where you don't even have enough people to do longer treatments for so many patients. So that's a big issue. And if you want to do it with CRRT therapy, well, those are designed to run for days. So when you use a set, which is expensive, the set of the filter and the disposables, which is multiple times the amount of money you pay for with Tableau or intermittent dialysis machines, those are designed to run a couple of days, up to 72 hours. They're not designed to run 10 hours, 12 hours and dispose. So that adds a cost. And CRT in of itself, because of the solution, they're not on demand for production. Those are expensive, and that's what the expense of running a CRRT program comes in, because of the CRRT solutions are expensive. And all of that put together, using an intermittent dialysis machine like Tableau, which gives you flexibility, but then it's very easy to use and easy to train folks for using it like you do with CRRT machine. It's a combination of the best of the features of both machines, and it applies itself seamlessly for SLED therapy, and that's why we use it in that sense. So I think this is one of the therapies, or one of the applications that really maximizes on the strengths of the machine, because every machine has its own advantages and the disadvantages, right? So a machine can do a lot of things, but it's too complicated to use. Machine can do one thing and do it very well in the case of continuous dialysis, but it doesn't apply to itself to other more flexible strategies. But then you have a machine which is flexible and it can do a variety of things. And I think if you buy into this SLED sequential, which is a very attractive way of doing dialysis, where you match volume management to the patient needs, and in my opinion, that's the most important part of patient management in the ICU, critically ill patient, then this is you're playing to the strength of the machine that you have in your hands. Let me stop there, and I'm sure I triggered a lot of questions. Cynthia?
Yeah, do you want to just
Oh,
mention
yeah,
about this slide, your site?
sure. Well, if you haven't got enough of me, there is a 5-minute video that I prepared about how to use Tableau in general. It has a brief introduction, and then he talks again about the SLED sequential. So if you forget about it, or you want to share it with someone else, or you want to pause and rewind as you see fit, please feel free to use the QR code to get to that page and view it. And put your like button if you like it.
Yeah, and it's a fantastic little vignette that, you did fantastic job having it be so creative, where you turn kind of into a cartoon. And other than seeing you as a cartoon, which I find hilarious, I think it's really helpful to visually see the differences in all the modalities and what you mean regarding the benefit of sequential SLED. So, as much as I'd like to continue talking, we have over 200 participants and a bunch of questions. So I thought I'd just jump right in and ask you a couple. Sound good?
Yes.
So can you comment, what percentage of patients who need dialysis in your ICU are on SLED? And do you use Tableau for intermittent dialysis too, or just for SLED?
So we started using Tableau for SLED only. That was this was a couple of years ago. And then, but we made it clear that we can use it for both. And this started actually during COVID, because we needed as many machines out as as were available, especially in our healthcare system that we had to share with some of the 10 plus hospitals which are part of the Cleveland Clinic health system. So at that time, we put a program together that the nurses actually, dialysis nurses, if they want to use the Tableau machines, or they don't have other Fresenius machines, which is our workhorse in our hospital-based dialysis unit, they want to drag the Tableau to the bedside ICU bedside, they can do it. And we made some adjustment to our order set where for all practical purposes is the same prescription, but if you want to use Tableau, because of the 200 ml per minute difference from 500 ml per minute for the Fresenius machine, you use a bigger filter. And we started with that because initially we didn't know if that's going to be sufficient. And then I'm happy to share with you some of our results which we were in the process of publishing, that it didn't make a difference. That F250, the bigger filter, compared to F160, which is our workhorse, that was enough to offset the small hit that you get with the lower dialysate flow, that the clearances were the same. So we basically left it to the dialysis nurse to choose which machine to take at the bedside, to dialyze the patient for intermittent dialysis, with the minor adjustment that the flows need to be to what the machine can do, plus use a bigger filter. And we've done that with no issues at all. Now, for SLED therapy, who I use it for SLED, a lot of times, at least we started for transitional care. We started our program, this was 4 or 5 years ago, where we wanted to take patients off CRRT and have something in between before we hit them hard with 3-4 hour treatments. Where a lot of times their blood pressure is not the greatest, they still have some volume on board, but we didn't want to run them even, but at the same time we didn't want the blood pressure to plummet as we're trying to take fluid out. So we started a transitional program where we use SLED in between continuous and intermittent dialysis. But then there are a lot of other applications where, patient comes in and they're not really need to be on continuous, but then they're not going to tolerate 3-hour treatment, or you're not going to be able to take fluid off. That automatically, buys them a SLED therapy or sequential therapy. And the other way we utilize a SLED quite a bit is to that sort of logistic scenario where you come in, you have so many patients, not enough dialysis nurses. Then we started a program, our daytime dialysis program, where one dialysis nurse will set up 4 or 5 patients on 6 hours SLED, and with the proviso that their UF rate is 300 or less, hand off patient monitoring to the bedside ICU nurse, and then go to the next patient to put the patient on. Now, there has been some limitations what patients get on. We don't use fistulas for those because there's no bedside ICU, the dialysis nurse staring at your access. The ICU nurse is the one monitoring. But a lot of times you don't need that. So you put them on catheters as if you're running 6 hours of 300 UF rate, and we put them on sequential. And then the efficiency introduced in that is one dialysis nurse or technician can run 5 patients within that 7-8 hour period. So that helps us, not start rationing, care in a lot of those when we have overflow, especially on Mondays or holidays or for whenever it gets busy. So that's another way we used quite a bit of SLED, helping us out in those crunches. And then the other thing is I talked about as well, where we want to mobilize the patient. Unfortunately, we have patients chronically in the hospital, need dialysis care for weeks, but they're not just, lying down. They are active, or they want to be active. They're mobilizing, but they're on respiratory. There are a lot of efforts to mobilize patients on CRRT, this and that, but this is much more elegant solution. You don't have to be on 24 hours. You put them on whatever duration they need, and then take them off for that 6 hours, 8 hours, 12 hours that they don't need to be on. And that's natural application of a SLED modality in those patients. I don't know if that's sufficient.
Yeah, and I think you answered a lot of you kind of touched on a lot of other questions in the chat. We have a couple of people asking, do you have protocol for poisoning and drug overdose at your institution?
Well, the protocol is that you have every modality in your disposal to do whatever you think is best. So these protocols work best for patients who are 90%, 99% of the time, you're just trying to meet your goal for volume management and soluble management. But if you have patient with drug toxicity or lithium toxicity or ammonia or whatever, and you think the best modality would be high intensity 12-hour dialysis, just dial it and do it. There's no, whatever guidance you have about that particular drug, toxin, or whatever, and what you think, or the blood levels, and you think what clearance for that molecule size and distribution is the best fit, you do it. The beauty of this is you don't have to try to do it with CRRT or IHD where nobody has done it before. You have the modality in your hands, and you're doing it anyhow. So it's just a minor change in the clearances that you specify and do it, and then you can do whatever you want. You basically a lot of people ask me, well, you have IHD, you have continuous, why would you do SLED? Well, I want to do everything that's possible so I can fit what's best for the patient. And that includes not only 4-hour or nonstop, that includes everything in between as well. So in a sense, you can do anything that you want, depending on what you're trying to achieve.
Right, you're personalizing it based on what's in front of you versus kind of being, boxed into certain parameters.
And you're doing it with not breaking the bank. You're doing it being even more cost effective. That's the beauty. Because, I can imagine whatever I want, I want to do this, I want to do that. Nobody's going to sign off on it if it doesn't at least make sense, cost effectively, because, so especially in this environment. But this, you actually are doing it in a more efficient and more cost-effective way. If you are thoughtful in the way you implement it.
Right. Yep. And then you don't have to think about it because when I'm at the bedside, that's not what I'm thinking about. I'm thinking about the patient in front of me, not necessarily anything financial at that moment. So
Exactly.
this helps with a specific guide rail so that you can meet all endpoints. So you mentioned it before about changing the filter because you're at a dialysate flow rate of 300. Just to review that, because we do have a question. So the question says, just to verify, the highest dialysate flow rate is 300. Any way around that? So
Anyway,
you kind of mentioned just some of the outcomes that you saw.
so when you're talking about SLED, you're trying to avoid over dialysis, right? So, a lot of times you do SLED or I do SLED because not because the clearance is the issue, it's because volume is the issue, because I want the patient more longer on the dialysis machine. So in many ways, I'm trying to curve down the intensity of dialysis. So that's not an issue. Now, if you're talking about intermittent dialysis, that you're talking about a patient who happens to be in the ICU and they need to be on 3 times a week and they don't have to be on more often dialysis, which is rare, but obviously it happens. It's rare because by the time you're that stable and you don't need any other needs, you're probably on the floor. You're not in the ICU anymore. So the point is, if you have that one-off patient who is in the ICU and he has no volume challenges, and all you need to do is 3 times a week dialysis, and you're worried about the URR, let me assure you that's an exception. And that exception is very easily remediable. What we do is we just use a bigger filter, and then I don't have to worry about it. Now, mind you, I check URRs on every patient. So if you are worried about it, and you should, you probably need to do it no matter what machine you're using, because a lot of these patients, they have access issues, they have flow issues, there are reasons that they come off, they have blood pressure issues. The blood flow that you think you're running, even if it says 400 or 350, believe me, it's not. If you had some sort of measuring it, it's not going to be as high because you have clotting issues, you have problems with the hypotension or increased pressure. Every time pressure goes up, that the number that shows as 400, it's not 400. So my point is, you really, if you are in a right patient, if you are worried about that, you need to use URRs or KT over Vs. You need to measure pre and post BUN for all practical purposes, and then adjust your prescription for next day if you have to. Very easy.
We have another person ask, the difference between Tableau and CRT, is it that Tableau does sequential SLED and the others do not? This person said they usually run about 20 hours.
So typically the way, if you look at the ATN trial, we were part of the ATN trial, which was published in 2008, run by Dr. Paul Plevsky from University of Pittsburgh. If you look at all the centers who was part of that trial, and you look at the median time on continuous dialysis in about 20 centers in the US, the time was 21 hours or close to that. So nobody runs 24 hours, right? Even if you're on continuous dialysis. My point is, define what continuous dialysis is, define what a SLED is. It's the way I see it is time on the machine. If my goal is to have a blanket solute control and have as much time on the machine for the UF needs, then what I can do is with Tableau allows you to run 24 hours. Then you change the set or the machine, run another 24 hours. Then what you can do is you lower it to the lowest rate that it can run, which is 50 mLs per minute, which translates about to 3 liters an hour, which is continuous dialysis rate. And then you dose your medication for CRRT, and you run it. That's one way of doing it. If you don't want to do that, if you want to run 12 hours and you want to have time for mobilization, or you can meet your UF goal in 12 hours safely by doing 300 an hour, which gives you what you need, and then you want to take the patient off. What I'm saying is do sequential, because that's the gray zone where traditional SLED sits, but we're not very good first in getting the right dose, because it becomes a guesswork. How much dialysate rate needs to come down, what blood flow rate I'm gonna do, what the phosphate is gonna do, all of that. You're risking antibiotic dosing problems, you're risking anti-epileptic dosing problems, if any of those are on board. Then do sequential. And you know how to, everybody knows, every nephrologist knows how to prescribe intermittent dialysis. Prescribe that 4 hour of diffusion, then prescribe the UF rate that you want for that patient and move on. That will solve 99% of the situations that you're in my opinion.
Thanks. We have so many questions. I hope we can get through all of them. So are you going to shift all Tableau machines for intermittent HD2? For smaller institutions, it may not make sense to have 3 machines, intermittent SLED and CRRT. Can you comment on that?
Absolutely. For us, we have a water treatment room that we invested in, and we have hooked up Fresenius machines or intermittent dialysis machine in our hospital-based unit. So we haven't converted to a machine which has an incorporated RO in it, right? So we're using those machines. But you're absolutely right. If you don't want to invest in a water treatment room, or you don't want to update it, or you want to get away with because you have a smaller center, or that makes sense, then if you want to have one machine that can do it all, then obviously this can fit the bill. And that's one of the beauties of having one machine that you train people on, and you don't have to sweat about people not having enough training because they haven't used one of those 3 machines often enough that they're good at it, and that's when problems happen. So do what's best for your hospital or for your infrastructure. It makes a lot of sense in a lot of situations. If you have one machine that can do it all, you do it all with that machine. My reason to incorporate Tableau in our work process was not necessarily replace all those modalities, but it was to chip away in some of those modalities. And we've done that over time. I don't know what the future brings, but that's what our approach was. And part of it is, we don't want to do anything drastic. We do 15,000 dialysis treatments a year. So, so that's a lot of treatments.
So you mentioned that. Do you know how many SLED cases you do weekly or yearly? You just said 15,000. Do you know how much of that is SLED?
So I want to say, I don't have the latest, but a lot of that is intermittent dialysis. So we do intermittent dialysis with Tableau and non-Tableau machines. But if you look at SLED, I think I had a slide from a couple of years ago that was maybe 5-10%. But I don't have an updated one.
Okay. And maybe I'll just combine the last question with a couple together. So people kind of want to know how often labs should be monitored during sequential SLED, your typical blood flow rate. If you could comment on that.
For sequential SLED, the blood flow rate is minimum of 300. A lot of times we write 400, but it's never 400 because, it's catheters, this and that. But typically, the nurse doesn't call us unless the blood flow is 300 or less, or less than 300 for all practical purposes. So anything 300 or 400 would be fine because, dialysate rate is 300. Now, if your dialysate rate is 600, then, if you're not running blood flows of 450, 500, you're not getting the most of the clearance that you think you're getting. My point is, as we've seen with our study, that most of the patients in the ICU don't have blood flows in their catheters that good. I mean, and even if you do, a lot of times you don't want to run blood flows that high if you have a fistula, even if somebody who was critically ill. So in a sense, this is not your chronic unit patient who you're running blood flows of 450, where you rev up the dialysate rate to 600 and you get the most of it. If you do, you will in the chronic unit. In the ICU, that's an exception of an exception.
Well, I think this has been fantastic. I know that I continue to learn from you and your experience, and I really appreciate it. I hope everybody really had a great time. This will be posted shortly for people to have access, as well as your website with your video. I want to thank everybody for joining us today. Thank you.
Thank you.